all the patients, through the development of the asymmetry, maxilla will follow the mandible. And this is regular in canting. When the mandible grow on one side vertically, the maxilla will be canted also. It is the same for lateral deviation. When the mandible is deviated to the right or to the left during the growth, the maxilla will be also deviated. And in all our cases, we did a Loeffler one associated to the USSO to correct the asymmetry. So all our cases has USSO on the lower, Loeffler one on the upper. Until now, I began doing it since 2005, but there are several publications, 4 publications about it. The first one of Ozdemir in 2009, about 12 cases. Waldwender, 26 cases. The team of Reinecke with Burks in 2015, 23 cases. And recently Len with 56 cases. Our series since 2005 till now is 169 USSO. This is probably the largest series ever done. You're wondering how come one surgeon in a small country like Lebanon, we have this big series. I think it's all question of indication. When you try to do USSO, you will find more indications for USSO. So USSO or BSSO, what's my first choice for asymmetry? It's always USSO. I try to cut the mandible on one side. Actually, all my cases are planned with the virtual surgical planning. I'll show you cases. At the beginning, we didn't use virtual surgical planning because we didn't have it to do it 3D. But actually, all patients are planned with virtual surgical plan. So at the beginning, I try to plan a USSO, and I look for the result. If the result is adequate, it's always my first choice. If the result is not adequate, I will switch to the BSSO. In those cases, BSSO being bilateral sagittal split osteotomy. What are the reasons why I switch for BSSO? Mainly it's because of the sagittal movement. When the unilateral sagittal split will not give me the adequate sagittal movement, or when I want to do a clockwise or counterclockwise, because the smile arc is not consonant, because for several other reasons. But mainly USSO, asymmetry, for me, first choice is USSO, and I'll show you why. What are the causes that make the mandible asymmetrical? Mainly there are 3. I will go through them. So the first one is the skull base asymmetry. Second, the shape asymmetry of the mandible. And third, the size of one part of the mandible. Skull base asymmetry, the first one. This is a patient with unilateral left coronal synostosis. When we look at the skull base, you will see that compared to the mid-sagittal plane, the bicondylar line is not at the same level. There is one condyle in front of the other. And if we position a mandible, I will represent the mandible as a triangle in this case. Even a symmetrical mandible will show on a frontal view as an asymmetry because the apex of the triangle is not at the mid-sagittal plane, as you see here. And even if we do a surgery to reposition this midline, we will shorten one side. The condyles are not symmetrical. This is what we will have. So at the end, maybe the midline is on, but the mandible is not symmetrical. So I'll show you one case. This is a patient with unilateral coronal synostosis. She was not operated when she was young. We try to orient as much as we can. It's not easy in these patients. You look at the mandible is asymmetrical. It is clearly asymmetrical. But when you look on the bottom view, you can see that the skull base is completely asymmetrical. And if we rotate and orient everything on the condyles, the mandible is normal. There is no problem with this mandible. But if we see that it is asymmetrical, we should treat it. In this cases, in this particular case, I did Loeffler 3 on one side, Loeffler 2 on the other side, plus Loeffler 1, plus USSO. So in all cases, we had a better symmetry of the mandible. as you see here. But in skull base asymmetry, USSO is not an indication. So first, skull base should be symmetrical to be able to use USSO. Second, cause of asymmetry, the shape of the mandible. This is a patient with an asymmetrical mandible, as you can see in the frontal view and in the lower view. If we take the CT scan, the problem of this mandible is that this patient has, that this patient has fibrous dysplasia, and this mandible is bigger on this side than this side. And it can be seen on other views. So if we represent the mandible as we see here, the right side is bigger. So if we rotate this mandible to have the body of the mandible symmetrical, the midline will not be on. If we do the opposite, so we center on the midline, the body will not be on. And so in all cases, this is not an indication for USSO, this is an indication for osteotomy. The opposite, the mandible is smaller on one side, hemifacial microsomia. So the problem of hemifacial microsomia is double. So this is the patient oriented. When we look at in a posterior view, you see that the level of the skull base of the condyle is not the same. So the skull base is not symmetrical to begin with. Second, the shape of the mandible. The shape on the right side and on the left side is not the same. The mandible is smaller on the opposite side. So if we represent it like this, and we try to correct the body of the mandible, we will lose the midline. If we correct the midline, we will lose the symmetry at the level of the body. So when the shape of the mandible is asymmetrical, this is not an indication for a unilateral sagittal split. But the majority of asymmetries, and here I can say more than 99% of asymmetries, are a part of the mandible that has grown more. In general, it is the posterior part, condyle or ramus. It has overgrown or undergrown. It's smaller or bigger than the opposite side. So I will do a little bit of math to prove that we can cut on one side and have a symmetrical mandible. So let's take the mandible, as I said before, as a triangle. And we will try to do a little bit of math. This is a patient with asymmetry. And as I said before, if you look at the maxilla, you'll see that the maxilla is also a little bit asymmetrical. And it is always the case in patients with mandibular asymmetry. So if we take this mandible, we orient the case. The mandible, the skull base is symmetrical. This is very important. Skull base should be symmetrical. Then, if we take the mandible and we rotate this mandible and we look only at the body of this mandible, we will see that the body of the mandible is symmetrical. So the shape is symmetrical, the skull base is symmetrical. This is the ideal case for us. So this is the mandible. I will represent it by a triangle. This is a scalene triangle, a random triangle. But as the skull base is symmetrical, so the mid-sagittal plane will pass in the middle of the bicondylar line. So it is the midline and it is perpendicular. If we take this triangle and we try to rotate on one side, on this case the left side, and rotate this triangle till the apex reaches the mid-sagittal plane, the opposite condyle will not move. This is normal. You cannot change the position of the condyle. And so we will have a new triangle. The base remaining the same, as the base is the condyles. So what are the characteristics of this triangle? This triangle has the mid-sagittal plane passing at the level of the apex, and it is in the middle of the base, so it is the median. As I said before, it is perpendicular, so it is the height. In any triangle, when the median is the height, this means that it is the perpendicular bisector at the base. This means that this triangle is an isosceles, and this is a line of symmetry of the triangle. This means that right, this triangle is unisosceles, the angles at the base are the same, and both sides are identical, and the mid-sagittal plane is the line of symmetry. And this is what we want. We want at the end to have the right side resembling completely the left side, and this is what we have. Let's do it differently. So this is the same triangle. We try to cut on the other side, rotate the angle to the triangle to the opposite side. The condyle will remain at the same position. We will have another triangle. This triangle has the same characteristics. So we have two triangles. These two triangles, as you see, are the same, but there is a difference in the projection, sagittal projection. One is a little bit bigger than the other. So theoretically here, we are achieving symmetry. This is nice doing it with math, but in practice, there still are three problems needing to be solved. First, in practice, are we capable of achieving symmetry to this mandible? Second, what about the sagittal movement we spoke about here? How much are we advancing? How much are we setting back? Actually, we are treating asymmetry, but in patients, we are not only treating asymmetry. We have to treat asymmetry, but we have also to treat the sagittal problems. So the patient has a class 2, has a class 3, the patient will need advancement or setback. And I think here are the problems where we can switch to a BSSO. And third, and this is the most important question, and I will take my time to answer about it, because every time I gave this lecture, I had hundreds of questions about the condyles. Are we rotating the condyle? Am I doing harm to the patient rotating their condyles? So I'll tell you a little bit what I think about it from where I came and everything about it. So to begin with, what are my inclusion criteria to say this patient is an excellent indication for USSO? First of all, skull base should be symmetrical. The shape of the body of the mandible should be symmetrical. When this is the case, and the cause of the asymmetry is the size of the ramus or angle, this is an excellent indication for USSO. We will prove it during this presentation. So my main indication, I said, the problem should be a problem of growth on the posterior part of the mandible, ramus, and condyle. It can be horizontal, and these are described as the lateral deviation of the mandible, but also can be vertical. So when we have hypoplasia of the ramus or the condyle, or hyperplasia. In the literature, you can find description about the lateral deviation, but never this description about condylar hypoplasia and condylar hyperplasia, where I think if the body of the mandible is symmetrical, this is the ideal indication, and I'll show you cases. So first, let's begin with the lateral deviation. As I said before, all my patients are actually planned with 3D virtual surgical planning, but at the beginning, I used to do it in 2005, clinically and on X-rays. So what is the typical indication? Who are the candidates? Candidates for USSO are patients who need limited mandibular sagittal movement. And we'll see later how much the mandible will advance or set back. So let's say a patient needs 10 millimeter of setback and has 2 millimeter of lateral deviation. This patient is not a candidate for USSO. So the patient needs limited mandibular sagittal movement. And more importantly, and this is the most important, translation should correct asymmetry. This is called the forced symmetry. So this is the patient. The patient has a lateral deviation. We ask the patient to bring the chin, translate the mandible to bring the chin to the midline. And we look at the patient. If the angles are symmetrical, this patient is an excellent indication for USSO. If the angles are not symmetrical, so when we correct the midline, the angles are asymmetrical, this patient is an indication for a BSSO, and we should do a yaw movement to give the angles a symmetrical position. And this is always done with 3D virtual planning. So when we have asymmetry, if you're not doing USSO, I think actually we should always do it with 3D virtual planning. I'll not go into the details of the 3D virtual planning, but you can see after surgery, the shape of the mandible on the PA set, it is symmetrical. The pictures, the result of the patient when we do a BSSO. So a patient who needs a limited mandibular sagittal movement where translation corrects symmetry, we say this patient will be treated with a USSO. How should we proceed? We should always finish with the low-for-1. Why? Because the mandible, when we cut it on one side, it cannot be moved freely as we wish. The opposite condyle is maintaining this mandible, and the opposite condyle will dictate the final position, transversely, anteriorly, posteriorly, and so on. To plan this, even virtually, we cannot do it 100%. So we should begin doing the mandible first, and then after having done the mandible, we will position the maxilla on this mandible. So remember the sequence, always low-for-1 last. So I'll show you quickly a patient. We do our sagittal split, then move the mandible. I like to use a splint that is flat from top to make me move the mandible freely without having intercuspation that can do parasite movement. So I fix the midline where I want, and then I put my screws, finish the mandible, do the low-for-1, and the case is finished. So I'll show you 4 cases, 2 advancement, 2 setback, 1 right, 1 left. This way we see all the cases. A patient with a lateral deviation to the left. We decided to do a unilateral sagittal split on the left, advancement, low-for-1, and genioplasty. So you see the deviation of the mandible. This is unilateral sagittal split, genioplasty, low-for-1. The patient after surgery, before and after. Profile before and after. The malocclusion corrected. The lateral ceph. The PA ceph. Second patient, also advancement, this time on the right side. So the patient before, we decided to advance the right side of the mandible. You see the lateral deviation of the lower midline. The patient, the panoramic and PA after surgery. The patient before, after surgery with the smile, before and after, and the profile. So now I'll show you the setback. As I showed you with the triangles, if we advance or if we set back, if it is symmetrical when we advance, it will be symmetrical when we set back. So when we want to try to do the forced symmetry, translate the mandible till the midline, we can do it even when we want to set back. So this is the patient, you see the deviation. We ask the patient to translate the mandible to the opposite side. If it is symmetrical, it is an indication for USSO. And this is the patient 1 year after surgery, before and after, and the profile. So we set it back, the mandible, advance the maxilla. So this one was on the right, this one on the left side, same problem, same solution. You see the patient before, we set it back on the left side, did the low-for-1, impacted the maxilla, the patient before and after, and the profile before and after. I'll not show you more patients, but this is the rule. This is the way we put our indications. Now, second indication, a patient with condylar hypoplasia. So this is a patient with hypoplasia on the left side. For this patient, we cannot simulate telling the patient to bring the chin to the middle. We cannot ask him to simulate elongating the ramus. So all these patients should be simulated with 3D virtual surgical planning. So these are the x-rays of the patient, and you can see clearly here how the condyle is hypoplastic and the ramus So there is a hypoplasia of the condyle and ramus. You can see the lateral self, the double border, and the PA self, the amount of asymmetry on this patient. So as I said before, we should simulate the patient with 3D virtual surgical planning. We begin with orienting the cranium. We look at the bottom view, and here, first, the skull base is symmetrical. So this is very important. Skull base is symmetrical. Second, we orient on the lower border of the mandible. And we look at this border, at the body of the mandible. The body of the mandible is symmetrical. So if these two are symmetrical, this is an indication for USSO. And then we will plan the patient virtually and see if we are capable of doing a symmetrical face with this. And you can see we can also improve because we are elongating one ramus, so we're doing a counterclockwise rotation of mandible. The mandible will go forward. We also print our splint for the surgery. But in these cases, when we elongate the ramus, in general, in hypoplastic mandible, the mandible is thin, and when we advance, we frequently have a problem at this level of the lower border. We can have a stair step, and some patients are complaining about it. You can see this patient, the patient who had this stair step here, you can see it here exactly, are unhappy and complains about it. So what I propose in these cases is to do the original of the Gezer osteotomy that was described in 57, probably a little bit elongated more to have more bone contact. So when we cut the mandible anteriorly, we don't go to the lower border, we go backward to the level of the angle. I'll show you some cases. So you see, during surgery, I go back to the angle here, so the lower border is remain intact. To elongate the mandible, I have to cut the muscle attachment laterally and medially. So I should remove the sling to be able to elongate the mandible and prevent having any relapse. So on the CBCT, you can see here that the lower border, the lower border is still continuous. For this patient, this is the panoramic of the patient before, the panoramic after, and you can see clearly that the lower border is left intact to prevent having this stair step, the notch on the lower border that bothers some patients. So this is the PA ceph of the patient before and after, the lateral ceph of the patient, and the picture. And you can see that we can correct condylar and ramus hypoplasia with the unilateral sagittal split osteotomy plus the 4-1. I'll show you quick, this is the profile, and then I'll show you another patient, but very quickly, same problem, same treatment, same result. So the patient before and after, and you can see we can correct the asymmetry of the patient by doing only a unilateral sagittal split, face, profile, and occlusion. Third indication, condylar hyperplasia. Same problem, same logic. When the mandible has grown on one side, posteriorly, more than the opposite side, why cutting one side and giving this side the same shape, the same size at the opposite side will not bring the mandible to a symmetry. So increasing the length of the ramus or shortening the ramus will provide us with the symmetry. So in condylar hyperplasia, we have two types, the active and the one who are not active. I will not go into the details. Even in the active, you can do a high condylectomy, then do USSO and do LO4. But there are one particularity in condylar hyperplasia. I'll show it. This is the patient with condylar hyperplasia. So as I said before, the sequence is always LO4-1 last. But in these cases, if you want to begin with the mandible, if we cut the condyle, if we do a high condylectomy, we will lose our reference to have the horizontal, where to position the horizontal, and so on. So I personally, and if we want to intrude the mandible, it's impossible to intrude because it will be hitting on the upper teeth. So in these cases, I always begin with the maxilla. So we do first the maxilla, or put it horizontal. Now we have an open bite on the side we want to shorten. We can do a high condylectomy and a USSO, or USSO alone, or a condylectomy alone, as you wish. So now we can do the shortening of the ramus on this side, but in all cases, and as you see here on the occlusion, we cannot predict 100% the final occlusion of the maxilla, of the mandible, because it is attached to the opposite condyle. And so in these cases, I finish with the maxilla. So I begin with the maxilla, I do my USSO, and then I finish with the maxilla. I'll show you the case. So then I finish with the maxilla to put it in the ideal position. So this is a patient with condylar hyperplasia who has done her orthodontic treatment, her aesthetic dentistry, finished everything, and then remembered that she is asymmetrical and she's not happy. So this is the patient. You see typical condylar hyperplasia. On the lateral PA-CEF, we see the deformity, and on the panoramic, if you look here at the condyle, you will see the huge condyle she has. The SPECT CT bone scintigraphy showed that it's not anymore active, so we don't have to cut the condyle. We can correct the mandible by doing a sagittal split. But what are the characteristics also of condylar hyperplasia? If you look at the height of the mandible on the right side and on the left side, you will see that it is different. Why? Because when the condyle was growing, there is an open bite that was created progressively, and teeth were erupting. There was a passive eruption posteriorly on the upper and on the lower jaw. And this is why the cant of the teeth is less than the cant of the lower border. So the height here is much bigger than the opposite height. Now, preparing for surgery, we can intrude the lower teeth and intrude the upper teeth, but I think orthodontists know better than me that it's not easy to do this. And so to correct the asymmetry of the lower border, we should cut from the lower border. But when you look at this X-ray, you'll see that it's not easy to cut on the lower border, and here we can touch the nerve. Why? Because teeth has erupted, but nerve remained on the lower border. And if you want to cut, in a lot of cases, we can injure the nerve. So I'll show you how we manage these cases. So at the beginning, this is the patient. We did the Le Fort one, and I put only 3 screws for the plate. Why? Not to have a lot of holes in the maxilla, in the upper part. And then if I want to do the second osteotomy to move the maxilla, I will not have the maxilla with plenty of holes. So I fix the maxilla, each plate with 3 holes. I do my open bite here. So I have the open bite. Then we do our sagittal split. The sagittal split I use is the one described by Ferguson. It's a very long sagittal split going till the level of the mantle foramina. So a very long sagittal split going forward. Then we can see the nerve, we can move the nerve, and then cut the lower border. Now, I'm sorry. A little bit differently than Ferguson. Ferguson removes bone from the upper part and rotate all the proximal segment. I don't like this because the height of the posterior height of the mandible will not change. So I personally prefer to cut everything from the lower border. This way, posterior height of the mandible will be shortened. And I'll show you one case during surgery, the same patient. So the sagittal split, as I said before, is cut very far forward to the anterior, to the level of the mantle foramina, as you see here. Then the split is done, and the nerve is moved. The nerve was positioned here. This was the canal. The nerve was moved to the top, and then now we can go and cut the lower border of the mandible. You can see here the cut we are doing on the lower border and remove from the lower part of the mandible. So this is the patient before and after, and you can see that the cant of the occlusal plane is corrected and the cant of the lower border is corrected. The same patient and at full smile. So I'll show you as all the cases, 2 cases from each. So this is another patient treated same way. This time it's on the opposite side, one on the left, one on the right. And you can see that the cant is corrected. This is very nice. I showed you several indications of USSO, but still, I did not answer the main 3 questions that I asked myself before. Are we creating a symmetrical mandible? Are we correcting the deformity on the frontal and on the profile? So on the frontal, is it symmetrical? And on the profile, how can we quantify the sagittal movement we are created? A patient who has a class 3, are we correcting this class 3? Second question, are we doing any harm to the patient by rotating the condyles? And orthodontic surgeons are like plastic surgeons. Plastic surgeons are always afraid of the facial nerve. We also are afraid of facial nerve. But when we do orthodontic surgery, our main concern is the condyles. Are we rotating these condyles? And actually, I will tell you a little bit. I did not, I never said that I could rotate the condyle before, but I think that we will speak about it. And are we doing any harm to the patients? Are patients having temporomandibular disorder after this rotation of the condyle? So first of all, is it symmetrical? This is a study that we have done with Dr. Maria Saadi and Ramzi Haddad, and 40 Lebanese orthodontists participated in the study we have done. So it has been published in 2020 in the Progress of Orthodontics. We had 4 groups of patients. The first group is 30 photo of patients who has lateral deviation, who were diagnosed to be a good candidates for USSO. And then 30 photo of the same patients 1 year after surgery. 30 patients of patient diagnosed of having proportional facial components. These patients were studies on PA, SEF, and we did the multiple triangle technique to say that these patients are symmetrical. And a 4th group of the same patients that we worked on Photoshop. We mirrored the right side, duplicated, and created 100% symmetrical face. So we had 40 files of 120 pictures sent to 40 orthodontists. Under each photo, we had a visual analog scale of 50 millimeters. On one side, 100% asymmetrical, on the opposite side, 100% symmetrical. And the orthodontists were asked to mark where do they think this patient fit. How much is the patient asymmetrical or symmetrical? So let's say this patient was here at 4.15 millimeter, and so he averaged 4.15 out of 50. And after having all these numbers, they were studied statistically. So these are the results. Between the group, pre-surgery, post-surgery, the mean difference was 14.22, and the difference was significant. So we can say that we improved our patients, but is it enough? So then we compared the post-surgery with our control group. And here the mean difference was 0.45. It was not significant. So practically we can say that we met our objective. We took this patient, asymmetrical patient, and we created a face that is like everybody's face. Then to go a little bit more deep in it, we controlled the control group with the mirrored group. And here the difference was really significant with a mean difference of 13.14. And also the post-surgery with the mirrored group, the difference was significant. But as we all know, completely symmetrical faces are almost non-existent. So there is no fully symmetrical faces in reality. And a study has shown that attractiveness, fully symmetrical face, computer constructed symmetrical face are less attractive than normal faces. This is the patient who averaged the highest score, 42.53 on symmetry, and this is the patient who averaged the lowest score. But when I look at this patient, I see even if I was doing a BSSO, I would not have done a better symmetrical mandible. So he averaged the lowest score, but it is also acceptable. Sorry, 1 second. So to answer the question, is it symmetrical? I can say, yes, it is symmetrical, and USSO achieved symmetry on the patient we studied. Second question, how to quantify the sagittal movement? So what are sagittal movements? When you cut on one side and rotate the mandible, the chin will go forward or backward. And in some cases, we need this sagittal movement to correct the class 3 or to correct the class 2. Now, actually, when we're doing the planning with 3D virtual surgical planning, it's easy because you can see that doing this will move the mandible forward or backward, and we know exactly how much it's going forward or backward. But before the virtual surgical planning, this was not the case. So Waldwender tried to put norms. He took a radius, a median of radius of 105 millimeters, and he calculated, and he said for x millimeter of translation, you will have advancement or setback of x millimeter. And you can see here that when you rotate, you have the curve. Reinecke, in his publication of 2016, he took 23 patients, did virtual surgical planning on these patients, and simulate 1 millimeter, 2 millimeter, 3 of advancement and setback, and he had a median of the movement. So approximately it was 65% in advancement and 70% in setback. So if you translate the mandible by advancing the sagittal split of 2 millimeter, it will advance by 1.31. This is also okay, but when you are treating patients, the patient has not all the same shape of the mandible. Some patients, as you see here, this is the curve, but if the mandible is bigger, you can see that the curve is not the same, and the movement will not be the same. And if the mandible is deviated, you can see that the curve is not also here the same than that the curve we will have when we have deviation. In our cases, we are treating patients who can have class 3, a patient who can have lateral deviation, and so we can use the same curve for all these patients. So we used to do something we called an individualized curve. So for every patient, we did their curve. And we did a prospective study on 20 patients. How was this done? First, we used to calculate the radius and draw a curve for the patient, and then we wanted to know if this was reproducible during surgery. So we drew a curve during surgery, and then we compare both of them. I'll show you. So to calculate the radius, it's not very difficult. If you have PA ceph and a lateral ceph, so we'll have A and B, and then we will be able to calculate the radius. So here we know which condyle will be rotating. We know where is the midline, so we can know the B. On the lateral ceph, from the condyle to the lower incisors, we have the A, and so we will calculate the radius and with the compass and tracing graph paper. We draw our circle. We know where is the midline. So this is the center of rotation. This is the midline. We go forward. This is our lower incisors midline. And we know now if you want to advance to translate 4 millimeters, how much we will advance. And if you want to go back, how much we will set back. Then this was the theory. We wanted to see if in clinic this is what was produced. We did for each patient a splint. This splint was flat on the bottom. And then before surgery, we put it on the mouth. We mark our midline. We do our sagittal split. We put a lead between the incisors, and then the mandible is free from the opposite, from one side. It's rotating around the condyle, and we draw the curve. This is our curve. We copy it on a transparent parchment tracing paper, and then superimpose both of them. So in all our cases, the two drawings were superimposed. What does that mean? This means that we can calculate, and the mandible is really rotating around the opposite condyle. But what was more interesting is that the individualized radius. Well, it's true that the medium is 108. It's like the 105 that was found by Waldwander, but we had mandible as big as 117 and mandible as small as 97. And if you remember the two circles, the curves are not the same. And so we cannot use the same radius for every patient. So our conclusions. First, like what was said by the team of Reinecke, in setback, there are more sagittal movement than advancement. When we set back, Reinecke said 70%, advancing 65%. This is true. When we set back, because we are in a curve, in a part of the curve that is going more down, so we have more setback than an advancement. The sagittal movement is bigger. Second thing is that it is inversely proportional to radius. This means that in big mandible, if you translate 4 millimeters, you will have less sagittal movement than in small mandible. So in small mandible, if you translate 4 millimeters, you will have more sagittal movement than in big mandible in class 3 patients. So these are important. In practice, they are between 50 and 70% of the transverse movement. To conclude this, and practically, if you're doing 3D virtual surgical planning, if you have a patient with limited translation, you want to translate the mandible 4 or 5 millimeters, and we said that it is between 50 to 70%. Here, the difference is not major. You can say it's 60%. In all cases, you'll not have more than half a millimeter advancement or setback because you have 4 to 5 millimeters of translation. And half a millimeter is not visible. But when we have a significant translation of more than 4 to 5 millimeters, ideally, we should do the individualized curve and calculate for the patient the amount of advancement and setback, as here we can have more than 1 millimeter of variation. Ideally, I personally prefer to do it with 3D virtual surgical planning, and here we can see exactly what we're doing. In hypo and hyperplasia, we should always simulate it, doing it with 3D virtual planning because we cannot simulate it on 2D. So this is for sagittal movement. Third big question, and this is the question where at the end of the presentation, maybe this will be the question that we will hear the more. In all my presentation, everywhere I gave this lecture, this was the main issue in all cases. Are we rotating the condyle? What am I doing? Rotating the condyles, is it acceptable? Aren't I harming the patients? If you know from where I come, I was a student of, this is my mentor, Professor Jean-Luc Béziat. I trained with this man, and he was defending during all his career, the repositioning system. So he did not accept that we do a sagittal split orthognathic surgery without repositioning the condyle and using this device to reposition the condyle in position. I did this during all my training and during the first 10 years of my career, I always reposition the condyle to position the condyle in the cavity and to prevent having any rotation of the condyle. So if I am speaking about rotating the condyle, I'm coming from a school where we don't like to rotate the condyles. And this is how we used to do. So before doing our surgery at the beginning, we had a splint in centric relation. We draw our sagittal split without fracturing it. And then we position a plate, thick plate, 2 millimeter thickness between the ramus and the maxilla. Then we remove our plate, remove maxillomandibular fixation, do our splint, put our intermediate splint. So we move the mandible, and now we put back the plate to put the condyle in its initial position. And I used to defend this technique, and I did not accept to do any surgery before without fixing this plate and repositioning the condyle in its position. So then we put our bicortical screws, remove the plate, and this is it. For years, I was convinced that I was repositioning the condyles in their original position. But is this true? If we take this picture and we advance the mandible, the only thing we're controlling is the pitch with this plate. But we are not controlling the yaw and the roll because of interferences. The mandible is bigger on the posterior part than on the anterior part. It's a triangle. When we go forward, always there is a rotation outward. When we go backward, there is a rotation inward. So there is no way we can advance the mandible without rotating the condyles. And here, I will show you quickly 2 studies. Advancing the mandible, there is always a yaw movement and a roll movement. We're speaking about bilateral advancement. Setting back the mandible, we have yaw movement and roll movement. And this is known, published everywhere, hundreds of publications about this. There is no way we do not rotate the condyles. In asymmetry, there is even more problem. And when we rotate the mandible, as you see here, we correct the cant, we have interference on one side, and this will create the proximal and distal fragment to be distant one from the other and create another asymmetry. And Dr. Ellis, who published this, and I think all the surgeons worldwide has used and tried his technique, we cut the distal segment to remove this interference and position the proximal segment in position. So we are rotating the condyle, but truly in asymmetry, should we prevent rotating the condyles? This is the main question. And I will begin by showing the BSSO, not a unilateral sagittal split, a bilateral sagittal split. So this is a patient, skull base symmetrical, body of the mandible is symmetrical, and this is our patient. If we take this patient and we want to correct the asymmetry, but without moving the condyles, is it possible? Yes, we will rotate the distal segment without touching the proximal segment. This is the final result. If you look at the same patient in a frontal view, rotate mandible and maxilla without touching the ramus and the condyle. I will tell you that if I were the patient, I wouldn't accept this result. And I would have preferred not having done the surgery at all. Because at the end, we did not correct the asymmetry. We corrected the midline. That's it. And at the end, the patient is still asymmetrical. So if I take the same patient and I want to correct the mandible to the ideal position, this would be the correction. I will do it without the mandible. So I remove the mandible and look at the condyles now. You will see that both condyles, I will do it back, both condyles are rotating, yaw movement. on both sides. I'm not speaking about unilateral sagittal split. I'm not speaking now about interferences, only to bring both ramuses in a horizontal position. Let's look at a frontal view. You can see the difference between right and left angle. We have 49 millimeter on both sides. On this side, it's inside the angle. This is the outside angle. So if you want to correct this asymmetry, this is what we should do. Perfect. Remove the mandible and look at the ramus now. This is a roll movement of the ramus. We cannot correct the asymmetry. We cannot have symmetrical angles, symmetrical ramuses without doing a roll movement. So to correct asymmetry, we don't have the choice. Or we preserve, in the first case here, we preserve the condylar position, but we are not correcting asymmetry. Or we have to correct asymmetry, and if we are correcting asymmetry, we are rotating condyles. Now I'll go to USSO. What is the difference between USSO and BSSO? In 2019, this is a recent study done by the team, by Dr. Lin. They were comparing the volume 1 year post-surgery of both condyles, right and left. What they did is bilateral setback, unilateral or setback, bilateral sagittal split, and comparing both of them. But we don't have numbers about the amount of rotation of both condyles. So in USSO, they did rotation, translation till 8.3 millimeters of rotation. And these are the results in the volume. On the non-deviated side, the difference is not significant. On the deviated side, there is a difference in both cases. Even in BSSO, if you look here, it's not working, that's okay. Even in BSSO, there is a change in the volume of the condyle. But the difference between USSO and BSSO is significant. And so in the deviated side in USSO, there is more change in the volume of the condyle, but we don't know exactly how much rotation they have done in USSO or BSSO. We don't know exactly if the indication was the same. So there are patients who are more deviated, patients who need more rotation or less rotation. I'm sorry. And then after that, they saw the difference in the midline correction between before bilateral and unilateral, and there was no difference between T1 and T2. So the results were stable in both cases. And then in the article, we find they speak about Farina. Other studies also demonstrated that changes in the joint can maintain postoperative stability as long as it is within the joint adaptive capacity. What does that mean? We see this is a cliche which we see in all publications. Can someone tell me how much is the capacity of adaptive capacity of the joint? Can we rotate 8, 9, 12? I don't know. But I think that the joint has an excellent adaptive capacity. We can rotate and we can have, as long as the midline did not change, the condyle is okay. And orthodontists know very well this because they use active appliances and they change the shape of the condyle and it is stable. So they concluded that both USSO and BSSO have demonstrated favorable postoperative stability. But still, till now, we don't know how much rotation of the condyle we have. So we conducted a study on a cadaver. We took the cadaver, drew 2 sagittal split on both sides, and we wanted to compare the USSO to something we know very well, the bilateral advancement and setback, which we know how much it is stable to advance the mandible and setback. And we want to compare the rotation of condyles in both groups. So we did the sagittal split on each side, removed 14 millimeter of bone, then fixed the plate, removed the plate, put holes between holes. So we can have a difference of 3.14 millimeter between 2 holes. And then we did CBCT to the cadaver. We had reference CBCT before doing anything. Then we did the USSO at the right side, advanced 3, 6, 9, 12, and did the CBCT for each one. Then setback 3, 6, 9, 12, did the CBCT for each one. BSSO 3, 6, 9, 12, advancement, symmetrical advancement, 3, 6, 9, 12, symmetrical setback. I'll not go a lot into details, and then we superimposed all of them on the skull base and studied the rotation of the condyle. And these are our results. So if we look at the side where we did a USSO, the homolateral side, we see that in BSSO, we have much more rotation. What are the causes of rotation in symmetrical movement? This is mainly interference. So the interference, when you advance, will bring the ramus outward. And when you go backward, it will bring it inward. On the USSO, it's also the interference, but here there is an equilibrium. When you go backward, the condyle, when you go back, the condyle will go inside, but in USSO, the mandible will be pushing this condyle. And in general, we have less movement of the homolateral split, the ramus and ankle. On the opposite side, mandible is advancing, there are interferences, and the condyle will be rotating outward and inward. In USSO, it's a simple rotation. There is no interference because we did not cut the condyle. And if we look here at the graph, USSO is in red, BSSO is in green. The difference between both of them is not major. And if we know that the majority of our USSO or BSO is between 6 and 9, we see that we are not rotating the condyle much more than what we are doing in regular osteotomy that we do every day. In the study of bugs and the team of Reinecke, they found 0.75 degree by millimeter of rotation, which is approximately what we found. So to conclude about rotation, what is my thinking today? Are we rotating the condyle? Yes, we are rotating, and we have to rotate because if we are doing a surgery to correct asymmetry, we don't have the choice. It's either we rotate the condyle or we don't correct asymmetry. So if we want to correct symmetry, we should rotate the condyle. Second, are we rotating the condyle more than what we do regularly in any surgery of every day? No, we are rotating the condyle the same amount we are rotating in bilateral sagittal split. So it's not a big deal as to rotate the condyle, as we have remodeling of the condyle, and the condyle, the mandible will maintain stability as the midline is stable. We reviewed 61 patients after 3.7 years, and we find the midline stable after 3.7 years. So if it is stable, there is no problem. Remains one question. We are rotating the condyle. Are we doing a temporomandibular disorder? So we called 94 patients who had USSO, 61 replied, and then we asked them questions, we examined the patient, and here are the results. Homolateral pain. This is the site where there is less rotation. So before surgery, we had 4 moderate pain. After surgery, in the 61 patient, 1 mild pain. So there is no increase in pain on the same side, but the same side did not rotate so much. The side who rotated more is the opposite side. So contralateral side. Before surgery, we had 3 mild pain. After surgery, we did not have any patient who had pain. So there is no pain on the opposite side where we rotated more the condyle. Now clicking. Before surgery, we had 10 patients with clicking before. After surgery, we had 4 mild cases. 1 of them is new. So there is clicking, but less than before. On the opposite side, which is the side where we have more rotation, before surgery, we had 15 cases. After surgery, we had 7. 1 of them is severe, the rest is mild. And one of the patients who is severe had translation of 10 millimeter. I'll show you the patient. This is the patient before. And you see there's translation of 1 centimeter and the patient after. The patient has only clicking on the opposite side, and this is clicking resolved with time. Now, if we go and compare to the bilateral surgeries, and this is a study done by the team of Wolford, of Dr. Laskin, and Ed Ellis, and you can see that there is a decrease in temporomandibular disorder for many patients in their study, but it can create symptoms in a smaller group. So actually, the USSO is not different from what we have in all-day practice. So to conclude, are we increasing TMD? I will not say decrease. I will never promise a patient, if he had the TMD, that I will heal him from his pain or clicking. But what I can say, that we are not increasing temporomandibular disorder because we are rotating the condyle. So this is what I wanted to say about USSO, and I will conclude with some slides. For me, when a patient has asymmetry, first choice is USSO. Because as I said before, the reason why the patient has asymmetry is a problem of the growth on one side. If you have a patient who has one leg bigger than the other, you will not cut both legs. You cut the one who is shorter and elongated, or the one who is longer and shortened. Why aren't we doing the same thing in the mandible? So at one condition, the skull base should be symmetrical. The shape of the body of the mandible should be symmetrical, and the only asymmetry is at the level of the size of the posterior mandible. So if this is the case, these are the inclusion criteria. The mandible is a candidate for USSO. And as I said before, we can change. We can begin our surgical planning by doing a USSO. And then if we're not happy about the sagittal movement, about the rotation of the occlusal plane, then we switch to a BSSO. So indications are clearly lateral deviation. Translation should correct asymmetry. In condylar hypoplasia and hyperplasia, we should do a 3D virtual surgical plan. The sequence of our surgery should be always low for one last. So we should begin with the maxilla, finish the position of begin with the mandible, begin with the mandible, finish the position of the mandible, and then position the maxilla on this mandible. In a particular case of condylar hyperplasia, I prefer to begin with the maxilla and finish with the maxilla. So it is in all cases low for one last. Are we rotating the condyles? Yes, we are rotating the condyles. And I'm not afraid of saying it today. So we are rotating the condyles to achieve symmetry, yes, but we are not rotating more than what we do in our daily practice in doing bilateral sagittal split advancement or setback, and we're not increasing the amount of temporomandibular disorder. I thank you for hearing me. This topic, I like it so much. I hope that I convinced the surgeon, the one who are surgeon, to try to do a unilateral sagittal split in your next asymmetrical patients. And I thank you for hearing me during this hour. Thank you so much.